This is not moving. Okay. Sorry, I'm having a little bit of throat problem. आज हामीले डिस्कस गर्ने the contents are cervical spondylosis, canal stenosis, lumbar spondylosis, lumbar canal stenosis, kyphosis, and scoliosis. Starting with the vertebra anatomy. Cervical vertebra, there are two types broadly, typical and atypical. First, second, and the seventh are the atypical ones because they have atypical features. The common that resembles to each other are the typical ones. So third to sixth are the typical ones. Like in this picture, you can see the spinous process and the lamina. This is a pedicle and the transverse foramen transversorum. This is the through which the vertebral artery passes. This is the transfer fasciate, articular fasciate, and these are the transverse process, and this is the body, and this is the lateral view of the cervical X-ray, cervical spine. So coming to the cervical spondylosis, what is it? These are the age-related degeneration of the cervical spine. This is the natural degenerative process of the cervical motion segment. The motion segment means the inferior end plate of the superior this vertebra, the intervertebral discs, as well as the superior end plate of the inferior vertebra, and the associated fasciate joints, associated fasciate joint. It usually begins at around 40 to 50 age and common in male. C5-6 in disc area is the most common one. Different risk factors associated are the excessive driving, smoking, heavy lifting in the head, and the professional athletes who have excessive neck motions. So coming to the pathoanatomy, the different components that give rise to the spondylosis that have changes in the spondylosis are the discs, intervertebral discs. They degenerate. That means there is a desiccation, loss of the water content, loss of the disc height, disc bulging, and possible disc herniation. Like here, this is the central canal. The disc herniates back. This is the calcification in the posterior longitudinal ligament, that is the osteophyte, and joint degeneration, and the uncinate sparring, and the fasciate arthrosis. Ligamentum changes, thickening and enfolding. Slowly, when there is instability, that leads to the kyphosis. The cervical vertebra is normally lordosis. There is lordosis in there, but because of the instability, and it might go into the kyphosis. The other part, a knob root compression. When there is a compression of the knob roots, and that give rise to the symptoms of radicular pain, radiculopathy we call it. And when there is severe compression in the central canal, we call it central canal stenosis. When there is less than 13 millimeter of the canal diameter, that leads to the compression of the spinal cord. The interspinal artery get compressed, and that leads to the ultimately central canal stenosis. We'll come to that later. So clinically, this cervical spondylosis presents as axial neck pain when there is a tenderness right here in the neck, and decrease in the range of motion, and the terminal range of motion becomes painful. When the nerve root gets impinged, there will be cervical radicular pain, unilateral arm pain, numbness, tingling sensation in the dermatum of this, like in this picture, and cervical myelopathy when there is a myelopathic symptoms and signs, when there is a gross compression of the spinal cord. So coming to the imaging, the most common we do is the cervical X-ray in the early stage. The degenerative changes we see in the uncovertebral joints and the fascial joints, osteophyte formation, disc space narrowing. Like here, these are the osteophyte bone spurs and the narrowing of the disc space. And there is like here the fascial joints, they have the sclerosis. Um, uh, in-plate sclerosis of the vertebral bodies. So these are the typical pictures of cervical spondylosis. We should also know the full collinear lines in the normal cervical X-ray. This is the normal X-ray, and this is the intervertebral line that goes along the interlongitudinal ligament, and the posterior vertebral line that goes along the posterior longitudinal ligament PLL. Third one is the spinolaminar line. Spinolaminar, that is the junction of the spinous process and the lamina. These also, and the last one is the interspinous along the posterior border of the spinous process. So these four lines make the collinear line to each other. When there is a break in the collinearity of these lines, there is something deformity there. There is something like you can see in this picture here, right here in this picture. There is a bridge in the posterior longitudinal line. So there is slight listhesis, anterior displacement of this probably C5, 6 vertebra over C7 anteriorly. So this reading of this cervical spine lateral view is very important. In the lateral view, we basically see the sagittal alignment of the spinal canal, yes, and oblique. This is the oblique X-ray. We see that this is the neural foramen. This you can appreciate this the quite narrowing of these two foramens here. That is obvious in the oblique view, foraminal stenosis, and the flexion and extension view. These are the, we call it dynamic views. When there is a, when we appreciate anticipate instability of the cervical spine, or even in lumbar spine, do it flexion and extension view. The lateral view taken in the flexion of the spine and the extension of the cervical spine, basically for the instability. So coming to the canal stenosis. When there is a stenosis, narrowing of the spinal canal in the cervical level, we call it cervical canal stenosis. It could be either congenital also, it could be acquired, that could be from the trauma or the degenerative process. Absolute and relative cervical stenosis. Absolute is less than 10 millimeter of the diameter, cervical diameter, canal diameter, and relative when 10 to 13. 10 to 13 is, above 13 is normal, 10 to 13 is relative. Relative means in dynamic X-ray we can see the compression of the cervical spinal cord in this relative cervical canal stenosis also. Imaging is the same, AP lateral flexion extension view. In this canal stenosis, there is the ratio we need to know, the Pavlov ratio. It's the ratio of the canal. You can see in this picture. This A is the canal, right from the spinolaminar junction and the posterior part of the body. This whole A is the canal diameter and B is the body diameter. Canal by body. If it is less than 0.8, when canal gets narrowed and the body is much less than body, then there is canal stenosis. MRI is the study of choice, and ultimately it leads to the cervical myelopathy. And the treatment is surgical decompression and stabilization. We'll come to this later. So what is cervical myelopathy? All this lumbar cervical spondylosis, cervical canal stenosis ultimately might progress into the cervical myelopathy. When there is significant compression in the spinal cord, this results in myelopathy, and ultimately characterized by the clumsiness in the hands and the gait imbalance. You must have already come across the ascending and descending tracks of the spinal cord. In this cross section we can see the sensory and motor tracks. I will not go into that detail, but all this compression of these structures result into the symptomatic symptoms of the patient that presents to us. As previously discussed, the cervical spine is around 14-degree lordosis, but when there is excessive degeneration, it might change into the kyphosis. Like in this picture, it has been measured as 11-degree kyphosis. It is taken from the posterior border of the C3 to C5 vertebral body. C3, one tangential line passing to C3 and tangential line passing through the C5. This is the way we measure the kyphotic angle. Different etiology are there for cervical myelopathy. Degenerative is one of them and is the most common one. Others are congenital stenosis, ossification of the posterior longitudinal ligament, tumor, epidural abscess, trauma, cervical kyphosis. The neurological injuries that result is from the either from the direct cord compression or ischemia secondary to compression of the interspinal artery. Imaging is the same. The spine most important view is the lateral view. AP lateral oblique flexion extension. The general findings is we have already discussed the degenerative changes, osteophyte formation, disc space narrowing, decrease in the sagittal diameter, and the cord compression usually occurs when the canal diameter is less than 13 millimeter. Another most important investigation is MRI, magnetic resonance imaging, what we call, and this is commonly done investigation. Different changes are effacement of the several spinal fluid and myelomalacia, spinal cord changes. Like here in this picture, we can see the increased T2 density in the inside the spinal cord. That means there is a myelomalacia. There's a permanent damage in the inside the spinal cord, especially in this T2 image. And we have one compression ratio, the ratio of the narrowest junction to the broadest nearby. This, if it is less than 0.4, this is poor prognosis. These topics I have prepared in depth in general. Basically, with these are prepared for teaching the residents purpose. So this may overshoot you, but this is good to know to all of you. I will skip the less important part for you. Okay. The other investigation are CT myelography. To get this gives information about the bony anatomy, and the discography that is quite controversial and not done these days. So coming to the degenerative cervical myelopathy, it is the most common, and compression usually by the anterior degenerative changes, these osteophytes and disco-osteophytes complex basically from the anterior side, and the degenerative spondylolisthesis, and there is a slippage. There might be slippage of the vertebral body one above the other, and the hypertrophy of the ligament of flavum may contribute. So how does the myelopathy presents? Neck pain and stiffness, sometimes occipital headache, extremity paresthesia, weakness and clumsiness, gait imbalance, and ultimately urinary retention. What are the signs? Proprioception dysfunction, basically from the dorsal column pathway, and the decreased pain sensation from the lateral spinothalamic tract dysfunction. Motor, there might be weakness in the hands and feet. Ultimately, the typical picture is the finger abduction sign. When ask the patient to extend the fingers, the ring and the small finger slowly drifts away. This is the finger abduction sign. Another sign is the grip and release test. In 10 seconds, we can grip and release up to 20 times. That is normal, but this myelopathic patient, they cannot do up to 20 times in grip and release test. And upper motor neuron signs. The different upper motor neuron signs are can be appreciated, like hyperreflexia, and the Huffman sign, the most common when we flicker the nail of the middle finger. There might be, we can appreciate the flexion of the distal phalanx of the index and the thumb. This is the Hoffman sign, suggestive of upper motor neuron lesion. Sustained clonus more than 3 beats in the ankle and the patella. We can appreciate this clonus. And Bavinsky sign, when we slowly what we say slowly toss the feet of the, like as shown in this picture, with the key or pin from the on the lateral aspect of the foot. There might be flexion of the toes and extension of the flexion and abduction, fanning of the toes and dorsiflexion of the big toe. That is the Babinski. And provocative test, we can do Hermitage sign. This is called when we flex the head, ask the patient to toss the chin, toss the chest with the chin, then there might be electric shock like sensation that pass in the body. That's the Hermitage sign. And there are different classification. This in depth is not required at your level. Different differential diagnosis of cervical myelopathy. One is normal aging process. When there is cerebral atrophy, people might come with the similar sign and symptoms. We need to rule out with that. And a stroke, yes, cerebrovascular accident we call it. And movement disorders, different vitamin B12 deficiency, amyotrophic lateral sclerosis, multiple sclerosis, and these all need to be differentiated before taking up the patient for the surgery. What are the treatment modalities? In the initial stage, we prescribe them medications, NSAIDs, and different pain modulators, gabapentin, and immobilization with a hard and soft collar as required. Physical therapy, neck strengthening, neck release exercise, and neck strengthening, balance and gait training. Operative surgical decompression. Since there is compression, we need to decompress it, and restoration of the normal lordosis and stabilization. This when there is significant functional impairment, 1 to 2 level disease, lordosis, neutral or kyphotic alignment, then we need to surgically decompress. Different modalities are there, like enterocervical discectomy and fusion, enterocervical corpectomy and fusion from the posterior side, posterior laminectomy and fusion, posterior laminoplasty, when we can combine both anterior and posterior. This is also not much required. In the 1 to 2 level, anterior alone is enough. When there is more than 3 levels, anterior plus posterior may be required. So this completes the cervical spondylosis, canal stenosis, and myelopathy. Okay, now let's jump to lumbar spondylosis. It's the same degenerative change in the lumbar spine. Everyone, usually 60 to 85% of people in lifetime, they get low back pain, and common is it's the common cause for the low back pain. Though mechanical back pain is the most common one. Okay, chronic low back pain, when it is more than 3 months, we call it chronic low back pain, and it's the most common cause is lumbar spondylosis. All degenerative conditions affecting the discs, vertebral bodies, and associated joints of the lumbar spine. Lumbar spondylosis and lumbar canal stenosis. This is the degenerative condition as mentioned, and narrowing of the lumbar spinal canal. It can be either from the bony structures as well as soft tissue structures. The bony structures are the fascia to osteophytes, uncinate process, and when there is spondylolisthesis, when there is slippage of the vertebra, like you can see in this X-ray, and there is a slippage of one vertebra over the other, and there might be canal compression from the superior corner of this inferior vertebral body. We call it spondylolisthesis. And different soft tissue structures that results in compression are, like we can appreciate in this. The disc has protruded posteriorly, resulting in canal compression, hypertrophy, and buckling of the ligamentum flavum right here from the posterior side. The ligamentum flavum has compressed the canal, and the synovials, fasciate cyst. These are the These are the bony and the soft tissue structures that might lead to canal compression. Coming to the pathophysiology, as discussed in the cervical also, the cell water and product glycan content in the nucleus pulposus decreases with the age. So there is ultimately, uh, because of the degeneration process, the disc height is decreased, and the buckling and bulging of the annulus fibrosus, this is the peripheral part is the annular fibrosis, this starts bulging inside and the canal, and the transfer of the force to the posterior elements like the fascial joints. So there is a fascial joints hypertrophy and the fascial joint arthritis, osteophytes formation there, uh, fascial joint hypertrophy, osteophyte formation, and ligamentum flavum buckling and hypertrophy, and ultimately leads to narrowing of the spinal canal. And uh, Tricaldi, Willis, and Bernard, they have given three phases of disc degeneration: stage of dysfunction, instability, and stabilization. So lumbar canal stenosis broadly classified into acquired and congenital. Acquired, it could be the most common is degenerative spondylotic changes. There are other acquired causes are post-surgical. After surgery, it might get compressed. Post-traumatic, after the vertebral fractures. Inflammatory and ankylosing spondylitis. And secondary to systemic disease. Second to systemic diseases like Paget disease, acromegaly, fluorosis. In congenital, short pedicles with medially placed fasciates. It can be idiopathic, congenital, and developmental, like we see in achondroplasia. Broadly, the lumbar canal stenosis has been sub-classified into 4 different types. It can be the central, when this canal is compressing, when the canal stenosis in the central level in the mid sagittal plane, that is central canal stenosis. And when there is a lateral, like in this number 2, sorry, here, and this picture also, and there is a lateral, on the lateral aspect, the exiting uh, exiting nerve, um, gets the descending nerve compression occurs in this, and a foraminal stenosis, when this is more lateral, like in this level, compresses exiting nerve root in this, and the extra foraminal stenosis, when there's far lateral disc herniation, like in type 4, the exiting nerve root gets compressed in this area. So broadly, there are 4 types: central, lateral, foraminal, and extraforaminal. Okay. And in this, we call it canal stenosis central, when there is less than 100 uh, millimeter. I'm sorry, this should be millimeter. 100 millimeter square, or less than 10 millimeter of the AP diameter in axial CT scan. Okay, some say it's also 12 millimeter, but most commonly followed is the 10 millimeter. Normally, the axial AP diameter is 15 millimeter, and the middle-lateral canal diameter, this anteroposterior, is the 15, and middle-lateral normally it's 20. Okay, when this anteroposterior is less than 10, we call it central canal stenosis. Similarly, in this foraminal also, when there's less than 4 millimeter height is lost, and the foraminal height is less than 15 millimeter, is seen in the oblique view. In the oblique view, we can appreciate the foramen, and this if it's more less than 15 millimeter, we call it foraminal stenosis. So symptoms, they usually present with back pain that refers to buttock pain, and sometimes referring back down the leg pain, often unilateral, and claudication, neurogenic claudication. May you have to know neurogenic claudication and know how to differentiate with the vascular claudication. The pain that works with extension, sorry, walking and standing upright. Pain relief with flexion. weakness, and ultimately may lead to bladder disturbances, and the recurrent UTIs may later come up, and sometimes there's sudden onset and the cauda syndrome might present. On examination, it is a KIM sign, though name is not famous. We call it extension test. When we ask the patient, when we are extend the back of the patient, there might be unilateral radicular pain, buttock pain that radiates low down. There's a KIM sign that these are present in the lumbar canal stenosis, and straight leg raise test. These are usually normal, unlike this in prolapse intervertebral discs. A Valsalva test also got more positive in the PIVD prolapse discs with a radicular nerve compression and radicular pain, but not seen in the lumbar canal stenosis. Usually, the neurological examination is normal unless patient in the late stages. So this is the important slide. You need to know the difference between the vascular and neurogenic claudications. Vascular is the arterial insufficiency. When there is it's commonly seen in the we call it Berger's disease or thromboangiitis obliterans. Okay, when there is a sclerosis of the wall of the arteries, and mechanism is ischemic. Okay, and the vascular claudication, unlike it can be mechanical also in the neurogenic claudication, and then there are component of ischemic also when there is ischemia of the interspinal artery that leads to the neurogenic claudication, but more is mechanical as well as ischemic. And the pain in the vascular is cramping type more of, and in neurogenic it is more of a radic type, and the pain location is usually in the exercised muscle, whereas this is in the lumbar sacral area and the buttock area, and it's down in the leg. Pain relieved by rest. It's not only rest, the flexion posture is required to relieve the rest in the neurogenic. Motor deficit is rare, and it might be variable, exacerbated by walking. After a short period of walking, patient may develop the leg pain and buttock pain, leg pain, and then we can have neurological findings also. Pulse decreased, normal. Arterial brew may be present, like it's absent. Arteriography is the diagnostic of choice when we can appreciate the narrowing of the arterial lumen, and it's normal. And lumbar MRI, CT, and myelography are diagnostic and the neurogenic. Other features like the loss of skin hair changes and the loss of this normal shining nature of the skin, these are more appreciated in the vascular insufficiency. Here, because of the low vascularity, the hair gets lost and the normal skin luster is absent in the vascular. The same, the X-ray changes are degenerative changes, osteophyte sclerosis, side and decrease, and degenerative scoliosis, spondylolisthesis, and flexion extension lateral view, and dynamic views. And MRI is the modality of choice. Central stenosis when ventricle sac is less than 100 millimeters square, and CT myelography. Third is the CT myelography. Okay. And the treatments are oral medication, non-steroidal anti-inflammatory, muscle relaxants, steroids, epidural, transforaminal steroids are given at the level of the compression when there is a compression associated edema is there. Then we can give the steroids, effective and may delay the surgery. Physical therapy, weight loss, bracing. Different operative modalities are posterior decompression is the mainstay of treatment. Central laminectomy, when there is a lateral stenosis, the fasciates can be removed up to 50%, not compromising the stability. Foraminal stenosis, fusion to decompression, maintain foraminal patency. Fusion is required if more than 50% of the fasciate is removed. Spondylolysis. This slide is not as important. During the operation, we remove this part of the from the steps 1 to 7. This is the surgical step not required. So this we complete the lumbar spondylosis, lumbar canal stenosis. So coming to the another disorder is kyphosis. Kyphosis, this is the normal spine, this is the kyphotic spine. From the picture also we can know that it's a deformity in the sagittal plane. Thoracic spine is normally kyphosis, increase in the curvature. This is simply the increase in this normal curvature, hyperkyphosis. Sharp posterior angulation, the Cobb's angle. We measure the Cobb's angle by from the tangential line from the superior end plate and the inferior end plate from the of the curvature, the deformity, and per line perpendicular to these lines, they meet and form angle. This is the angle of kyphosis. 10 to 40 degree is normal. We may take from T5 to T12. Okay, the different types. Postural, it can be also postural because of the flat feet, excessive lumbar lordosis, posture training exercise, and structural kyphosis. When there is structural change, this we call it structural kyphosis. So structural kyphosis it can further be subdivided into congenital achondroplasia, osteogenesis imperfecta, adolescent kyphosis, Scheuermann's, and adults tubercular ankylosing spondylitis, trauma, infections, and elderly the osteoporosis, osteoporotic fracture. So structural kyphosis different: congenital, adolescent, adults, and elderly. There are different causes for that. And we should know this in three terminology: knuckle, gibbous, and angular kyphos. Knuckle deformity is from the one or two vertebra collapse when there is just sharp posterior angulation of the usually the dorsal vertebra, and we call it knuckle deformity. Gibbous, two or more vertebra gets collapsed, and from this kyphosis, increase in the kyphosis, then we call it gibbous deformity. And angular, more than three vertebra are involved, that gives the more diffuse angular kyphosis. We call it angular kyphosis in that. Knuckle, gibbous, kyphosis, okay, angular kyphosis. So congenital kyphosis, there are different cause of the congenital kyphosis. Congenitally, there might be failure of the formation, right? In this only part of the vertebra forms, so there might be this results in the kyphosis. So this is the failure of the formation, and other is failure of segmentation. In the normal in the developmental process, this vertebral bodies get segmented. When there is loss of failure of segmentation in the anterior part, this fused part does not grow much, so only the posterior part grow and gives the kyphosis. And mixed, there can be mixed type also. The important one is the adolescent Scheuermann's kyphosis and juvenile dorsal kyphosis. We also call it vertebral osteochondritis. Is the cause, exact cause is not known, and probably hypothesized to be the collagen defect and defective ossification of the ring epiphysis of the superior and inferior end plates of the vertebra. So anterior part of the vertebra is less resistant to loads than the posterior part. So anterior wedging of the vertebra occurs, and it has two types. Type 1, only thoracic involvement. Type 2, thoracolumbar involvement. Sorenson has given radiographic criteria for the Scheuermann's kyphosis diagnosis. More than 5 degree of wedging. We can appreciate this. The intervertebral height is less than the posterior. So when there is more than 5 degree of wedging of at least 3 adjacent vertebra, more than these 3, you can appreciate more than 5 degree of wedging of the 3 adjacent vertebra. And kyphosis more than 40 degree in the sagittal plane. Up to 40 degree is normal, so more than 40 degree is kyphosis. And thoracolumbar spine kyphosis, which is usually 0 degree, is if it's more than 30 degree, this meets the Sorenson's criteria for the adolescent Scheuermann's kyphosis. Okay, the different other signs are vertebral in-plate irregularities, disc space and narrowing, and there are different associated lesions in this. Okay, the clinical features at puberty around 13 to 16 years, in common in boys, increasing round shoulders. We can appreciate backache and fatigue. Usually patient they present with a pain while carrying heavy school bags these days, and backache. Smooth thoracic kyphosis, compensatory lumbar, like here we can appreciate compensatory lumbar lordosis in late life lumbar backache. In imaging, see, we can see the irregularity in this picture. irregularity of the vertebral end plates. There is a wedging of the vertebra. The vertebral height is less in the anterior than the posterior. And the same is seen in this X-ray also. And we call it small snode. Small snode is nothing but the axial disc protrusion. Usually the discs, they protrude inside the central canal, but sometimes due to the pressure, axial pressure, it might protrude in the superior end plate and inferior end plate also. This small radiolucence is seen right here also. You can in the MRI also. These are the small nodes. And MRI, like in this picture, in plate irregularities, wedging, these are can be appreciated. So in the treatment of Sorenson kyphosis, adolescent kyphosis, if it's 40 degree, around 40 degree, back strengthening exercise and postural training is all that is required. If it is more than 40 degree, bracing, you can see the bracing for 12 to 14, 20 to 24 months. If it is in older adolescents, when the growth is potential is less, young adults with rigid curve more than 60 degrees. So older adolescent, young adults, rigid curve, instrumentation, fusion, operative surgery is required. So this completes the kyphosis. Okay, and now coming to the scoliosis. Scoliosis, as seen in this picture, there's a lateral deviation of the vertebra. Normal vertebral spine is vertical, less than 10 degree. So if it's more than 10 degree lateral deviation, we call it scoliosis, associated with complex rotational deformity of the vertebra. Actually, this is a three-dimensional deformity. It's not only the lateral deviation, the vertebra also get, but body gets rotation, and there is a deformity in the sagittal, coronal, as well as axial plane. Okay, different types: non-structural, structural. Non-structural, as in similar to the kyphosis, position also. In kyphosis, what we have said, short leg. When there is short leg, it can be like in this picture, short leg, a hip contracture when there's flexion in the hip also, sciatic scoliosis when there is PIVD and severe spasm in one side of the low back muscles. And then they also gives the list, we call it list things here. So these are the non-structural one, and this gets normal on sitting. This spine gets normal straight. Okay, the structural, the non-correctable deformity with vertebra rotation, non-correctable deformity. Different types of scoliosis. This is the healthy vertebra. We can see thoracic, when there is curvature in the lateral curvature in the thoracic region, thoracolumbar, lumbar, and thoracolumbar, and combined. Okay, based on the location of the scoliosis. It can be idiopathic, infantile, when there's seen in 0 to 3 years age, juvenile. Can you all hear me? Juvenile 3 to 10 years, and adolescent more than 10 years. The other causes are neuromuscular, myopathic, congenital, failure of formation and segmentation, degenerative, traumatic. Clinically, it presents with the deformity, rib hump, pain. See, this is with the lateral rotation of the vertebral bodies. One part of the rib becomes prominent, like seen in this picture, and this gives the rib hump. Okay, deformity, rib hump, pain, and usually runs in the family, so family history. On examination, this is the Adams forward bending test. On asking the patient to bend forward, the vertebra should be well aligned, but in this picture, see, there is a prominence of the ribs in this right side, so this is the deformity from the scoliosis. Iliac crest height, like in this picture, uneven shoulders, curve in the spine we can see, and uneven hips, uneven iliac crest height. The arm trunk gap we can appreciate in this picture, and the scapular position, the trunk shift, and different neurological findings in, and the scoliometer. In this picture we can see the scoliometer. This is the scale to measure the scoliosis. In imaging, the angle of scoliosis is same measured by the Cobb's method, from the superior and inferior end plate of the deformity, and the line and perpendicular to this gives angulation. The different X-ray, PA, lateral, bending views, traction views, and stagnara view. This is a typical view picture. In this different angle perpendicular to the vertebral body, we can see. And to properly define this, the angle of deformity, we need to get the stagnara view, but that's quite difficult to get. And these days CT scan, 3D CT scans are well available, so this stagnara view is not commonly done these days. And AP view pelvis for the riser sign. This is the riser sign showing the epiphysis of the iliac crest. Slowly it starts fusing from the lateral towards the medial side. So 1, 2, 3, 4, and 5. When is based on the percentage: 25, 50, 75, 100%. It starts ossification from this side, and when it's completely fused, it's stage 5. That means the spine has matured already, fully matured. So this suggests how much maturity is remaining and how much the spine has matured. CT and MRI for operative planning, left-sided curve. The common is the right-sided one. If it's left-sided, then we need to do CT and MRI with neurological defect. Failure of formation, failure of segmentation, the congenital causes. And the failure of formation, we can see the unsegmented vertebra and fully segmented vertebra. Only half of the vertebra are formed. Wedge vertebra, when there is a wedging. And failure of segmentation, when the vertebra do not differentiate from each other. This we call it block vertebra. And when there is one part is remaining unsegmented bar, we say, and mixed type. These are the congenital variants. So progression: curve with Cobb's angle less than 30 degree at maturity, unlikely to progress. 30 to 50 degree curve, 10 to 15 degree progression in lifetime. More than 50 degree curve progresses 1 degree per year. And more than 90 degree curve, significant compromise in pulmonary function. Treatment of the scoliosis, basically it's observation on the early stages, and the bracing in the middle stage, and if it's a gross deformity 40 to 50 degree, and more than 50 degree and higher, surgery is required. The different braces are Milwaukee brace and Boston brace. When the cervical extension is Milwaukee brace, and the Boston brace on the thoracic lumbar. And surgery, like we can see in this picture, and the deformity has been well corrected by the posterior instrumentation. Thank you all. Stay safe. If you have any questions,